The first patient, this was a 66-year-old. He had BCG-unresponsive non-muscle invasive bladder cancer. It was diagnosed and thoroughly worked up at an external institute that came to us for a second opinion regarding either, upfront early cystectomy or a salvage other intravesical treatments. He had his imaging, CT urogram, CT chest, all appropriately done about 2 months prior to seeing us. So, and at that time, there was no evidence of extravesical or metastatic disease. Given that our clinical workflow at the time is that we would do ctDNA, so Signatera, in all patients that have high risk NMIBC. So we sent a ctDNA and that was positive at baseline for him. That triggered us to do additional imaging. So we ended up getting a bladder MRI, CT chest abdo, and that showed that he had locally advanced disease with pelvic sidewall involvement as well as pelvic adenopathy. So eventually, this patient went on to receive systemic therapy with EV Pembro, and he did have a great response to therapy. His ctDNA eventually declined from initially being positive all the way down to 5, then negative, and then he ended up getting consolidated cystectomy down the line. And then our second patient, so this is another 70-year-old male. He also had BCG unresponsive disease, but instead he underwent salvage intravesical therapy with gemdosi. So he finished induction. We did blue light cystoscopy, random bladder biopsies as per guidelines that showed no evidence of disease. He had some erythematous patches, but all were biopsied and negative. However, 2 months later, his ctDNA became positive at 0.04, and at baseline it was 0. This prompted us to do additional imaging. So we did a bladder MRI that showed there was some non-specific bladder wall thickening, but nothing that overt you could say was a mass or anything like that. Nothing that we saw on cysto either. So given these findings, we discussed the case at our multidisciplinary genitourinary tumor board, and the board said, why don't we take an earlier look in? So an earlier ctDNA triggered diagnostic bladder biopsy as well as upper tract cytology. So we did that, and that cystoscopy probably happened, a couple weeks from that point, and it showed a SESL 2 centimeter bladder mass. It was confirmed to be T1 high grade with extensive lamina propria invasion. So that patient initially was scheduled to continue gemdosi, but because of the ctDNA positivity, followed by positive cystoscopic findings, we ended up shifting gears to radical cystoprostatectomy. And his pathology was actually PT2B. So it wasn't just, persistent T1 high grade. He was upstage as well. We had a third patient, which, in a paper like this, like we didn't just want to present the positive findings, right? So we had a patient that initially, at the time that the paper was published, it was a bit confusing. So a 70-year-old female had a history of T1 high-grade bladder cancer with concurrent CIS. She had induction BCG, was again negative on blue light cystoscopy, cytology, as well as negative imaging. But her ctDNA was positive initially at 0.21. And then we kind of monitored these within every 3 months as per clinical workflow, and it went up to 0.25. And at the time, restaging imaging, MRI, abdomen, pelvis, CT chest, everything was negative. So we also did a repeat TUR for her. We think at the time there were just some erythematous patches that were no overt tumors, but it did show T1 recurrence. And we eventually took her to the OR a few weeks later. She had categorized as BCG failure, and her final pathology was actually PT1N2. So her ctDNA positivity triggered the earlier TUR. And that again showed that she had an occurrence in upstaging.
As Dr. Wang shows, even though these patients were appropriately staged, they've had CTs, MRIs, they've had cystos that were triggered earlier on. All of these patients were upstaged to a higher disease. So none of our patients that we ever did a cystoprostatectomy had TA or T1 disease. They've all had been T2 or N1 or N2. So I think it's very important discussion to have with the patients when their ctDNA is positive, that we are at that risk that potentially more intravesical therapy, the salvage therapy, is likely not going to be curative, because ctDNA is it's a poor factor in all bladder cancer, but particularly in these patients where you have an opportunity for cure, it's very bad prognostic sign.